Okay, welcome. Hi, everyone. Good morning, good afternoon. My name is Heather White. I'm the Executive Director at Together for Health, and I'm pleased to welcome you to the Together's ongoing webinar series highlighting several topics in global cervical cancer prevention and control. Today's webinar will focus on the collaboration among several key partners in Rwanda, including the Rwanda Biomedical Centre, the Elekta Foundation, Society for Family Health, and the Clinton Health Access Initiative. Together, their pilot project has screened more than 20,000 Rwandan women for HPV and treated several hundred through Rwanda's health system. We'll hear from each of their teams on the contributions and working towards a joint vision of cervical cancer elimination in that country. Following the presentations, we will open the discussion up for your questions, and I encourage you to share questions and comments with our presenters in the Q&A box. You're welcome to put questions in the box at any time, and we'll do our best to get to all of those. Before we begin today's session, just a few housekeeping notes. Please note that all attendees are on mute. Following the presentation, we'll have roughly 20 minutes or so of Q&A. If you do have a question, please write it in the chat box as I mentioned, and we will get to as many as we can. And note that this webinar is being recorded and will be available on our website after the event. A link to the recording will also be sent to everyone who's registered for this event. If you're interested in learning more about this or similar topics, please do let us know. At the end of the presentation, we will post links on how you can get on our mailing list and contact us directly with any ideas or feedback. We're sincere about that. We do want to hear from folks as to what presentations and learning are important for your respective organizations. So please do reach out to us. Okay, this morning we'll get started. I'm going to briefly introduce and welcome each of our presenters on today's webinar before we get started. So if you'll give me just a moment to introduce each of our speakers. This morning, first, we will hear from Dr. Francois Uwikindi from the Rwanda Biomedical Centre, where he serves as Division Manager of Non-Communicable Diseases. Dr. Francois is a medical doctor with a master's degree in epidemiology from University of Rwanda. He has previously served as the director of the cancer diseases and has served for more than 5 years in Rwanda's national HIV control program with different roles and responsibilities in prevention, care, and treatment, monitoring and evaluation, and clinical research. Welcome, Dr. Francois. Following his presentation, we will hear from Lacey Hubbard, president of the Elekta Foundation. Lacey brings more than 2 decades of industry experience in running operations, developing service products, and leading transformational programs. As former VP of Global Education and Training, she has instituted many changes within Elekta's learning strategies, content development, and digital learning. Additionally, she has led new product and service implementations across the globe, including Europe, Asia, and the Americas. Lacey holds a Bachelor of Science in Educational Engineering from Shanghai, China, and an Executive MBA from Washington University in St. Louis. Following Lacey's presentation, we will hear from Irene Kabitesi from Society for Family Health in Rwanda. Irene is a business development and projects manager at SFH Rwanda. She brings 10 years of work experience to this role, having managed projects from a variety of donors and having developed behavior change communications across multiple sectors, including water, sanitation and hygiene, cervical cancer, HIV and AIDS, malaria, nutrition, MCH, and health system strengthening. She holds a Master of Science in Development Studies and a Bachelor in Social Sciences. And finally, we'll hear from Ngandu, whom we will call Nana, from Chai. Ngandu is a Senior Associate Monitoring and Evaluation, Senior Associate in Monitoring and Evaluation at Clinton Health Access Initiative in Rwanda. She's a seasoned health promotion practitioner with a focus on monitoring and evaluation, knowledge management, community health, and digital health solutions across several disease areas. She studied development studies at the University of Zambia and holds a Master of Science in Public Health Promotion from Leeds Beckett University. And with that, I will turn it over to you, Dr. Francois, to get us started. Thank you.
Okay, thank you so much. Again, thank you so much for inviting us to present what you are doing in terms of, accelerating the elimination of cervical cancer in our country. And of course, where we'll be focusing mainly on the powerful partnerships, because as a country alone, we cannot do it. So we are working very closely with different partners, and one of them is Elekta Foundation. So today, as it has been introduced, we will present how we've implemented our project to be able to screen over 20,000 women in a very short period. So if you allow me, I can maybe move my slides. Who is moving? Yes. So, and I think we all know these 90, 70, 90 targets. So these are the targets that all countries have to reach by 2030 to be able to eliminate cervical cancer, or to, yes, in the next century. And also Rwanda is also committed also to be part of those front runners to be able to reach these targets. We are even being more ambitious to reach these targets even before 2030. And I think this is very common to many people here. So the world will be able to say that we've eliminated cervical cancer once we have less than 4 cases per 100,000 women. So, and these targets, once we have to reach them by 2030, but also be able to maintain them. So that's when we can be able to reach, the elimination targets. So as the country, we've started even, let's say some time back, because we now have a mature cervical HPV vaccination program. It has started back in 2011. And since then, we've really registered very high coverages, because since the beginning, we have now more than 93% of young girls are now vaccinated. And this is a very strong pillar towards the elimination of cervical cancer in our country. But you know that we need also to be able to screen these older women that didn't have a chance to be vaccinated when they were adolescents. So this is, I think, something that is making us very, very busy now, to be able to increase our screening coverage, to be able to reach now also these global targets. So this is the work that we have started, and we are working with different partners here, and also one of them is the Elekta Foundation. So the strategies that we are using, of course, we have now adopted HPV DNA-based screening strategy, and also decentralizing the screening at the primary health care level, where we are taking those samples. We do the testing at the district hospitals, where you have molecular platforms, but also once the results are back, we send them back to the health centers. They do VIA, but also we build the capacity for those nurses from health centers level to be able now to treat those simple precancerous lesions using thermal ablation machines. And this is really helping us to reach higher treatment coverages for precancerous lesions, but also to be able to implement a sustainable program. We are also including these screening services in the benefit package for different health insurances, including also the community-based health insurance. So, and then you know that while you are screening, you also have those women with invasive cervical cancer. We should also be able to treat them efficiently. And then the country is also very busy in building a strong treatment capacity, strong treatment services through availing adequate equipment, but also we have recently started our local fellowship training program in oncology, so that we can have now really a critical mass of really well-trained doctors and nurses to be able really to treat efficiently or effectively our patients that we're having with invasive cervical cancer. And also we are happy that now all of these diagnoses, but also treatment services are covered by existing health insurances. And this is also really promoting access to these services. So to be able to do this, so we can say that we are happy now that really we have a very strong protocol and support. So, and this is really something that has started, as I said, like 12 years back, and it really continues. But also, we are promoting a multi-sectorial collaboration to make sure that really everybody is brought on board, and we have really, we are putting together all our efforts, but also happy that we are having now long-term, but also meaningful partnerships to really to be able to do it. And then what we are doing, we are making sure that we are able now to capture information. That's why we are building strong and also interoperable digital systems to enable tracking of implementation, but also achievements. That's when we can know that we are on track achieving these targets by 2030. Next. So this is this webinar is really focusing on the second pillar on the screening. So this is really showing where we are now. As I was saying on my previous slide, so we are still far behind this target, but I think we are making a progress. But we also know where we are going. This is very important. We even have a plan for 10 years that will help us really to reach these targets. So these are the services that now are working in around 6% of all health facilities. And if you take numbers from 2017, we have been able to screen around 465,000 women. So over just 5 years. So, but if you look at the numbers of women eligible for screening, we are estimating those women around 1,600,000 women. So it means that really the gap is still high. But so to be able really to go faster, we are combining screening campaigns, but also integrating these services into routine services at different facilities. So if you look at the coverage at the national level, we are around 25%. But if you go to those facilities with functional screening programs, the coverage is relatively higher, so 46%. So, but again, the goal is to reach 70%. But the good news is that with the decentralization of treatment services at primary health care level, we are able to reach this good treatment coverage for precancerous lesions. We are now at 91%. So this is also, we are also very hopeful that really in a very few years to come, we should really now be able to reach this target of 70%. Next. So these are the strategies, and I think I've been talking about those strategies while presenting my two previous slides. So, I mean, to make sure that really we are reaching to those women, we are doing service integration. So using different existing services at primary health facilities, HIV services, maternal and child health services, but also in the general consultations, where women can receive message, awareness, information about cervical cancer, and then they are directed to these cancer screening clinics or areas at the facilities, and then they can get those services. But again, in the community, for the demand generation, we are using different strategies, but mainly using community health workers, but also media and also local leaders, so that they can really teach people, but also encourage them to come to the facilities. So again, in this framework of integrating, not really implementing a vertical program, the testing is being integrated into existing platforms that are being used also for HIV, for viral load at different facilities. So these are platforms that we are using. But also, as I said, this is very, very key. Decentralization of treatment of precancerous lesions at primary healthcare facilities by nurses and midwives, and we have seen that it's really safe, no major side effects. So, and this is something that is really done quickly. In less than 1 minute, the treatment is done. So, but we continue, after training, we accompany our providers with mentorship, but also supervision. But also, this is very important. We have electronic patient tracking systems that are helping us really to track the movement of women, but also capturing data that will show the progress that we are really making. So briefly, in a nutshell, this is what I can say about what we are doing in terms of, scaling up cervical cancer screening services, focusing at our primary health care facilities. So I will let my colleagues really continue with the rest of the presentation, and they're happy to continue discussing during the Q&A time. Thank you so much.
Fantastic.
Thank you, Francois. Hi, everyone. I'm Lacey Hubbard. I'm president of Elekta Foundation. I am super happy to be here today because this is my favorite topic these days. As a person who has worked in different settings around the world, I have seen the challenges and opportunities in cancer care. So Elekta is a global company that has been leading radiotherapy equipment to treat cancer for over 50 years. But we don't just build a technology, we build hope. Just over a year ago, Elekta launched a corporate foundation, the Elekta Foundation, with a mission to improve access to cancer care in underserved countries. And cancer prevention is one of our focus areas. So as you heard from Dr. Francois, Rwanda is committed to eliminating cervical cancer. They are on the mission, and our Elekta Foundation decided to join them. Last year, we partnered with Rwanda Biomedical Centre, the RBC, to develop an enhanced model by stress testing 20,000 women for HPV with high throughput and a better accuracy in cervix screening. Our model has shifted from disease-centered care to women-centered care. So these women can have access to services more easily. We consider 3 elements in this model: distance, how far these women have to travel; time, how long they have to wait; and the cost, how much they have to pay. We offer end-to-end approach that covers screening and treatment, cancer detection, and advanced treatment within a short period of time. And the next month, we will also start building community-based care for these cancer patients with the support and education from local health workers and community health workers. So our goal was not only to detect cervical cancer, but also to treat it so these women could resume their abnormal lives as soon as possible. We want our model to be scalable, be able to reach more people, and adaptable, flexible enough for different contexts for Rwanda and other countries with similar settings. I want to share with you roughly what our workflow looks like. Next slide. So here, it's a little bit blurry, but I show quickly. So on the left side, as Francois said, the country has such high vaccination rate. So this project is not including vaccination. So started with screening. We set up 20 local health centers to collect self-samples for HPV. Now, these centers are not too far from these women, so they can walk there in 30 minutes to 3 hours. By the end of each day, these centers will send their samples to the district hospital where we have built a HPV testing lab from scratch. If a woman is tested HPV positive, we will call them back for a follow-up. During her VIA examination, the nurse will immediately treat her with thermal ablation if they detect any precancerous lesions. However, if the lesions are more than 70% or they see any suspected cancer, they will send her to the district hospital so the doctors can further examine her and perform the LEAP procedure. And during the LEAP procedure, a biopsy will also be performed at the same time. If pathology shows cancer, then this woman will have to go to Kigali, the capital city, for a cancer examination at a referral hospital. Depending on the cancer stage, they will receive surgery or other treatments For example, if their cancer has grown outside of cervix, right, they will have to receive 6 to 8 weeks of radiotherapy with chemo. So as Francois was saying, and from September to December, in less than 4 months, with all our partners, hard work, we finished it, testing 20,000 women for HPV. And we have treated more than 600 women with a precancerous lesion. And so far, 9 women has been diagnosed with cancer and are receiving cancer treatments right now. So we hope our project will contribute to reducing the burden of cervical cancer for women and improve their quality of life. And this ends my part. Now I want to let Irene to talk about their wonderful work.
Thank you, Lacey. Thank you, everyone. My name is Irene Kabatesi. I work with the SFH Rwanda. Before I proceed with SFH contribution towards the project, let me tell you a bit about SFH. SFH in full, Society for Family Health, is a local NGO established in 2012 in Rwanda. Its goal is to inspire healthier lives in the country. So we provide communities with readily accessible life-saving products through social marketing. We disseminate accurate health information and services that empower communities to make informed and healthy choices. That is social behavior change communication, and that is what we are going to talk about shortly. And third, we deal with health system strengthening through contribution to the universal health coverage. This is done by establishing what we call second generation health posts, which we'll talk about in detail in the future. So what was the role of SFH in this noble cause? The role of SFH was to ensure that eligible women are mobilized and go to health facilities to get these services that were tailored for them. So first, through social behavior change approach that SFH used, we commenced by stakeholder engagement. Because our stakeholders who were mainly local authorities in Gicumbi district where the project was implemented needed to know about what's going to happen. So they were engaged, and through different meetings, and maybe we can look at the main actors that were engaged. First, the vice mayor in charge of social affairs. He's the key person in the district in terms of health matters, and other team of 53 people in total. So this team, this session was led by SFH, RBC, and CHAI representatives, and we had a good discussion about how the project was going to be implemented in Gicumbi district and what each person's role would be. Second was capacity building. Next. Capacity building of key actors. Those are the coordinators of the project, social behavior change officers from SFH, whereby they were introduced to cervical cancer, being SFH first time to deal with cervical cancer. And I take this opportunity to applaud our partners, RBC and CHAI, for the capacity building sessions we carried out together for our team to get on board to be able to mobilize the target women in Gicumbi district. From there, we went straight to Gicumbi, whereby 2,363 community health workers were trained on cervical cancer. They were given basic information on cervical cancer and also on message delivery. How do you deal with a prospect patient of cervical cancer versus any other person? How do you do that? So these trainings were conducted in partnership with, of course, our stakeholders, RBC and CHAI, and they went perfectly well. As you can see, these were the key actors who enabled the achievement of the project targets to reach 20,000 women with the right messages about cervical cancer, and also encourage them to go for HPV testing. The third group of people who were trained, who were given capacity building as far as cervical cancer is concerned, are representatives of people living with HIV. Why? Because mobilizing this category is not done in public, in open. So that's why this group was approached separately, so that they can be able to reach out to their colleagues, and being also members of Gicumbi district, as it was indicated by available data. So this team also was trained and was able to help this category. Next. After the capacity building session, now messages had to be delivered. The women had to be reached. There were different channels that were used to be able to reach the eligible women, target women. So community health workers carried out door-to-door visits to households with these eligible women. So community health workers, they are volunteers, and they stay in communities at village level. So they were aware of where these eligible women stayed. So they would go to their households through door to door. We also conducted different radio talk shows, radio spots, mobile sound system, whereby a pre-recorded message on cervical cancer was played repeatedly, and a mobile sound system would move around the district for to ensure that no one is left out, at least with the message, and then the issue of taking the decision to go to the health facilities came next. We would also go to marketplaces. We would create special groups, gatherings, and different meetings. So through those interventions, we were able to mobilize 20,417 eligible women. They were reached with the right messages as far as cervical cancer is concerned, and also they took the right decision to go to nearby health facilities for HPV testing. And from that, we worked with our colleagues to the next step. So on average, during that period, 510 women were reached and tested for HPV on a daily basis. So through that process, of course, we encountered some challenges whereby women, there were some rumors in the community that HPV testing is painful. They were comparing it to the previous experience they had, but HPV was new. So it sometimes created a resistance, which required our team to put in more effort and educate those women and explain to them the difference and also the process. And that was done, of course, in close partnership with our stakeholders from RBC and CHAI. So another challenge encountered during the campaign process is, of course, these are rural women, they are farmers, and they had to go to work. Of course, their daily routine had to go on. So that required team members to work extra hours, long hours, late hours to be able to reach those women. They sometimes they had to wait for them so that they come back from the farm and come for the HPV testing. So that's, of course, it was a challenge, but it was overcome through that. Another kind of challenge I can mention, the HPV testing took place from health facilities, and sometimes these women would go to work far from the health facilities and would inform our colleagues in the field that they cannot get time to go there. So what was done in close partnership with our stakeholders, we created secondary sites whereby they would be mobilized but get the testing services near where they're working from. That also helps to get to the results we managed to get. So, so that's it for now. Thank you. And your questions and clarifications are welcome. Thank you. I would call upon my colleague, Nana. Thank you.
Thank you. I am Nana and I'm from Clinton Health Access Initiative. I'm going to speak on the capacity building aspect of the program. So the main aim of the capacity building in this program was to ensure that the see and treat sites were activated and able to provide screening services to the women in Gicumbi district. In total, the aim was to activate 29 screening sites in Gicumbi, including the district hospital. So the training approach was in 2 phases. The first one was the intensive didactic training, which was conducted by national trainers they were drawn from the larger pool of existing national trainers who have been trained by the Rwanda Biomedical Centre. So we have the pool of existing national trainers. And they used the national training materials that have been developed for the country. So this training was 1 week theory, which involved taking participants through theory sessions of using PowerPoint slides, using other materials for practicals for simulation and practical exercises during that theory session. And following that, there was on-site practical sessions that were supervised by the national trainers in the healthcare provider's home facility. The second phase was the on-site mentorship. So this was post-training mentorship, which was conducted immediately after the training. So this was aimed at improving the quality of care that was being provided at the health facilities by the providers that had recently been trained. So they conducted their initial screening sessions under the supervision of the mentors. So these are the national mentors that have been trained as mentors who were placed in the different facilities and providing this post-training mentorship. And then after that, the next stage of the mentorship was targeted and focused on specific facilities and identified gaps. And then just to speak on, so this is the training approach for the healthcare providers, and this training was delivered to the clinicians. This is the outpatient nurse, midwife, family planning nurse, and HIV. So this is where the providers who were trained were coming from. And then we also had the training sessions for the laboratory technicians to make sure that the laboratory system was set up to be able to run the HPV testing. And then we also trained data managers so that they were able to also manage the information from the program. So the clinicians were also trained in some components of sample management and data management, because they during the screening, they're the ones who, as they collect the sample, they need to handle it well in order for the analysis in the end to be reliable. So they also had those components. And the training for the clinicians was also, it focused on screening, which is screening with HPV tests, as well as visual inspection with acetic acid. And then also treatment using thermal ablation, because there's the treatment of precancerous lesions that are below 75% of the cervix were conducted by these clinicians. So they also had to learn to be able to conduct treatment using the thermal ablation device, and also providing information in the facility and counseling for the patients at every stage. So what we were able to achieve from this training was expansion of screening service access points to 24 health centers, 1 hospital, and 4 health posts. And also the setting up of the HPV diagnostic network in the district. So from sample being collected at the health facility, transportation of the, storage of the sample at the facility, transportation of the samples to the district hospital where the sample analysis was being done, and also the handling of those samples, and up to the stage where women actually received their results and were also called back for treatments. The other was the setting up of the functional information management system in the district. So this enabled providers to access information with ease using the electronic patient management system, and also provided the national level access to the information on the cervical cancer screening for decisions, like, for instance, monitoring the data to observe whether women who were testing positive on HPV were coming back to the health facilities for the triage and treatment. So it was possible for all this information to be, it was possible to monitor the program offsite using the information management system. And also through the Gicumbi project, we were able to integrate enhanced VIA using the corpuscope into the existing training model and, well, eventually the screening model. Dr. Lee will speak more on this. And then there was also, we also achieved setting up of the referral pathway. So during the training, the healthcare providers were trained on the existing referral pathway and also being able to identify which patients needed to be referred to where. I think we can move on to the next slide. So with the questions on sustainability of this training and mentorship for the see and treat. So the training approach and materials that were used in this project have been adopted by the Ministry of Health. So these are being used countrywide. So we believe that even some of the providers that have been trained in Gicumbi could also be those that perform well could actually be integrated into the pool of the national trainers. And this training approach is a component of the costed national scale-up plan for cervical cancer secondary prevention in Rwanda. So it creates opportunities to scale up the model to other parts of the country. And then also the existence of the National Cervical Cancer Monitoring and Evaluation System set up in the district. It provides information for decision-making at national level. So this is one of the ways that this training and mentorship approach can be sustained, because we are able to see and make decisions with regards to the successes and merits of, or any gaps in the training approach that is in use. And the established national screening program model, which is being supported by other partners in the country. So as this model is scaled up, other partners are coming on board and they're able to use this model to implement the cervical cancer screening program. We did have some challenges in the different components of the program, but more specifically to the capacity building. With the training in the laboratory system, we did have challenges, as we were required to continuously train and extend the periods in order to achieve our goals. And this was mainly due to the fact that with the Gicumbi project, since we were stress testing a model and we targeted to screen 20,000 women in a period of 6 weeks. So in order to be able to screen the women, taking their HPV samples, sending them to the lab, getting the results, and having them to come back to the facility for further management, we used a testing platform that was being used for the first time in HPV testing in the country. So because it was new and it was a platform that was going to allow us to actually get a large volume of results within a short space of time, being a new platform, we did have challenges with getting the laboratory network working as we expected. So this was a major challenge on the training aspect. Thank you very much. I will now hand over to the next presenter.
Okay, I'm back. I will go really quick because I think we Heather want us to keep it short, so we have a Q&A. In our project, we introduced several digital solutions to improve efficiency and accuracy, and I will highlight a few here. Nana talked about quite a bit about this electronic national systems, and Francois also mentioned that. So in project, in each center, we call this POC, has a tablet connected to the central system. They register women and they're tracking the HPV testing and follow-ups. And because these tablets can share data to the central system in real time, so this part I love the most. So whether I'm in the US or in Sweden, through this WhatsApp group, I know exactly what's going on in the roll-up number or each center in if I want to drill down. So this is absolutely wonderful. The second, we also introduced a barcode system for HPV. As you can see on the screen, these sample tubes only have barcodes, no names. So the lab workers don't know who has HPV, right? So when the result is out, the software converts the code to the woman's name and phone number. This ensures their privacy. In the bottom, and Nana also mentioned this mobile colposcopy device. So we introduced this device, a portable device, to all the C and the treated clinics. It's like a smartphone camera, but you can zoom in very close, like 5x, 8x to even 12x. And take a crystal clear pictures like what you're just seeing on my screen. And this helps the nurses to see much better than the naked eye. And one nurse told me he loved this device because it makes him more accurate and also confident to avoid overtreat patients or undertreat patients. And this device also has a built-in software that lets us do telemedicine. So we also did a feasibility study. It worked well because Rwanda has good 4G connections everywhere. Now this means we can get more help from experts in big cities, even future from outside country support. So to sum up, cervical cancer is a highly preventable and treatable, and digital solutions can accelerate and enhance our efforts to eliminate this disease. I think that's in our presentation, Heather.
Thank you, Lacey, and thanks to everyone. And I mentioned to the team yesterday that this is probably my favorite slide that I've seen recently. All of the photos, really the people whose lives are touched, the women that we're serving, that you all are serving. Your work is so inspiring to me, and I'm very grateful to you all for sharing some of the overview with us today. I'm going to get us quickly moving into the Q&A session because we have just about 10 minutes or so. But I wanted to also let everyone know that we have another guest, Dr. Hwanching Lee, whose company provides the mobile colposcope. He has also joined us for a Q&A. So if you all have particular questions about that product, please do put those questions to Dr. Lee. And welcome to everyone. Let me run us through the questions that are still open in the Q&A box. And the first one is a nod and a acknowledgement, and thank you for the work that you're doing. The question is for Lacey, but I'll actually open it up to the panel. Lacey, feel free to take the question on first. What strategies do you have in place to screen more women nationwide in the shortest period possible? If you all would like to talk a little bit about sort of what your next steps are in this project and how you see scalability. Thank you.
Sure. Well, to really improve, we have such a big population need to be done. So to me is how we develop a model with high throughput and with quality. This is really what I see as a woman-centered care is really the way to go. You have the woman can get there, so the time, distance, and the cost. So the distance really makes difference for the woman in the working distance. They can participate, and we talk about time already. The cost is another way, right? Because it's expensive. And I just answered some questions earlier. Somebody asked me the average. You look at this model, we are looking at average $25 per woman to doing the end-to-end. So the strategies improve this one is open up more centers and doing the same time, because we proved we can get 500 to 600 women to show up a day. And the lab can also now with the training and now we have a capacity, we can do 600 easily. And then you can duplicate this model and you have the proper funding. And that really why we cannot do another district and simultaneously. And or if we're doing Rwanda, why we can do other countries at the same time. So that's my thought. Another thing I want to add on is our second project, we want to also add a breast cancer screening, because this woman's already there and you can do, we're doing this project already. But next one, we will bring some other equipment, like a portable ultrasound as well, because that way you can reduce the cost, right? And that the woman's already there, the campaign, the other expenses, it's already done. So we can bring more services at a reasonable cost.
Thank you for that. Does anyone else want to take on the question of sustainability while we're talking about that here? I'll just give a moment. Okay. I would love to turn to a question for Dr. Francois, and please, Dr. Francois, I don't want to put you on the spot, but I will say that you all know as well as I do, many of these early programs, pilots, and let's say relatively small demonstration projects in cervical cancer prevention struggle with how they gain enough traction to really start to plug into the national health system, take advantage of national health insurance schemes and coverage for women, particularly as women move through the continuum of care, right? And they're looking beyond pre-cancer treatments to something that would be more invasive and obviously more costly. Could you speak to what it took from the government perspective, from the national perspective, to be able to really make the commitment towards a vision of elimination from RBC and other colleagues within the ministry? I would, if you don't mind, I would just love to hear you say a bit about what that took, because I think many countries really struggle with this challenge. Over.
Yeah, thank you so much. And first of all, as I was saying, there is really this very high political will. So we are lucky to have a government-centered, a people-centered government. So working for its people. So if you look at really what we started even some work before there is this global cervical cancer elimination strategy. We started our vaccination back in 2011. And the coverage has been really over 90%. I can say that really we've already achieved the first objective or the first target, but again we have to keep it high, and also because this is not something that you do once and stop, you have to continue. So this is really to show how really this issue of really women health, is really a very dear, dear project or dear really issue for our government. So because we know the value of the women in our societies, in our families, but also their contribution to the social development of the country. So even this cancer, this is a cancer that we know the cause. This is a cancer that we can be able to prevent by vaccinating. It's a cancer that we can be able to screen early, and also treat and stop the progression towards having I mean, invasive, and prevent it to reach invasive phase. But also it's a cancer when it's detected early can be treated. So meaning that we have tools in our hands to be able to eliminate this cervical cancer. But this is exactly what is motivating us as the government, as the Ministry of Health, really, because we have tools in our hands, we can do something, and really, it's also like a real issue. If you look at the data we have from our National Cancer Registry, this cancer comes at the second position after breast cancer. But if you look at the mortality, it comes at the first position, meaning that people are coming at advanced stage, yet we can put in place systems or strategies to be able to detect this disease early and be able to treat effectively. So these are really reasons really behind this motivation, this political commitment, political will to be able now to say that, okay, we can really eliminate this cervical cancer and have really a generation free of cervical cancer in the next century. So, and then to do it, I mean, we need to have resources on the ground. So the government is investing a lot, putting in place, those treatment services, making sure that facilities are equipped, but also including these services, in the health benefit package. But also, that of course, if you want to go far, better you go with others. So that's why really we've also mobilized these additional partners, not only for the screening, but also for the vaccination. Well, when we started the vaccination program, we've worked with America as the company that is manufacturing, the vaccines. But later we are working with Gavi, but also government is also contributing to these vaccines. There is eco-financing, a counterpart contribution. This again is really a sign of really this commitment, but also other partners, development partners, implementing partners to make sure that really we are all putting together our efforts. So that's really what we work also to do now for the screening. So working with these other different people, but also the government is also putting resources to make sure that really we can, of course, be able to show the entire community, the global community, that really this is possible. And while investing in these, services, the returns on the investment is really huge. So not only, economic return actually is really huge, because these are exactly, and also if you look at the age, our women are having this invasive cervical cancer. It's coming, they're having it while they are still in their prime age, still active, still strong to work for their families, for the community, for the society, but also for the entire country. So these are really reasons behind this motivation from the top level up to really technicians and also our partners that we are working together with to really be able to, to eliminate this cancer, because it's possible.
Yeah.
Thank you.
Thank you, Dr. Francois. That was very inspiring words from your perspective, and thank you for sharing. I just want to give the floor to the issue quickly. We're running out of time, so this will be our last question. But several of you have asked or talked about the integration of breast and cervical cancer screening. We do have a question about how do you logistically make that work, given that those are different age groups for screening ages. I don't know, Lacey, if you're best placed to tackle that question, but it would be great to talk a little bit about the integration of those two services, because I think many programs aim to do that, and would love to hear your perspective. And once you answer your question, then we will sign off. But thank you everyone for joining, and happy to connect you all if there is more learning that we can share across. Over to you, Lacey.
Sure. So the question is, do we plan to integrate the breast cancer screening? Is that right?
That's right. Yeah.
Absolutely. We are going to. In fact, we have announced a second project in the same district, because we did a 20,000 women. There are still 35,000 women still remain at high risk of cervical cancer. But with that, like I said, we are already adding the breast cancer screening in the current program. But for the next one, we will add in there, because if you're thinking about women-centered care, and we don't want them to today got to take care of a cervical and the cancer, and the next day die from breast cancer, right? So this is it's very important when I talk about model to develop it, is how you have this, let me repeat myself, the woman-centered care means distance, time, and the cost. How long they have to walk, how long they have to wait, how much do you have to pay? So when the women's already go to local health center and health posts, you will do the both, right? So HPV testing versus like doing self breast test. And then if there's any abnormal, we introduce some portable device there to see further, to check, that can be operatable by nurses. And that itself allows women to have a more, what should I say? It's not only, then it's from there you can even inspire more, right? If they're there, why cancer? Why can't you check their blood pressure or something else? If it's a woman-centered care, that's important. They are healthy in all aspects. So that's one you want to go. From the cost affordability wise is, instead you have taken care of the cervical cancer, then you do another breast cancer service. And that's expensive, double expensive. But how we leverage this too, and we can reduce the cost. That is what's our pilot project for. And as a beginning, I was saying, we working with Francois' organization is really see what is the model that we can scale in Rwanda and Africa country. And that is, I'm happy to share. And if you have any good practice and any good ideas, please reach out to us and join us.
Thank you. Listen, I appreciate it again, everyone. Thank you for your time. And for our listeners today, don't hesitate to reach out if you have additional questions, thoughts, comments for this group. Happy to share those across. I wish everybody a good day, good afternoon, good evening, and we'll see you on our next series. Again, thanks everyone so much. Take care.
Thank you, Heather, for organizing this.
Thank you. Thank you.
Thank you.